So, all right. Hello, everyone. Thank you for joining us this evening. I'm your host, McKenna Campbell. Before we start the presentation, I would like to share a little bit about the association. ACS is an international association of healthcare professionals on the forefront of cannabinoid medicine. Founded by physicians, ACS is uniquely positioned to advocate for the higher standards in practice of cannabis medicine. We are an advocacy organization striving to guide lawmakers and regulators at every level of cannabis control. We also prioritize inclusivity and value having members from all walks of life, which motivates us to provide discounted memberships to qualifying groups. Uh, I went out of presentation mode. That's okay. On this next slide, you can see that there are many benefits to joining ACS. For all of ACS's constituents, we provide evidence and experience-based education to support the premise that cannabis should be treated as a medicine. Please feel welcome to reach out to us with any questions about membership. For our student leaders, we encourage you to learn more about our Student Ambassador Program. And now, on to our speaker for the evening. Dr. Eugene Vortsman brings a comprehensive understanding of substance use disorders and harm reduction strategies to his role as a prominent figure in addiction medicine. Dr. Vortsman is also deeply engaged in psychedelic education, advocacy, and harm reduction initiatives. He is committed to promoting a compassionate and non-judgmental approach to substance use, whether it involves cannabis, psychedelics, or other substances. Dr. Vortsman continues to drive forward the conversation on holistic approaches to healthcare and the importance of harm reduction in medical practice. So as I stop my screen sharing, please help me welcome Dr. Vortsman.
Thank you, McKenna, for the introduction. Much appreciated. So I'm going to just share my screen and let's dive into it. Okay. So first of all, quick introduction. Again, as McKenna said, my name is Dr. Eugene Vortsman, dual board certified in emergency medicine as well as addiction medicine. And today we're going to do our best at finding a balanced conversation about the potential risks associated with cannabis. Course doesn't go. So no pertinent disclosures. To dive in just to a general framework what we're going to be discussing today, some of the learning objectives. We're going to highlight how cannabis has changed in recent times. We're going to discuss the obstacles related to evidence-based medicine, focus on how cannabis impacts different demographic groups, highlighting pre-birth impacts with post-birth life, as well as elderly risks with common medicines and contraindications, and finally, emergence of cyclic vomiting syndrome and how it impacts our daily life. So this is where we were. We were reefer madness, and I hope that we'll never ever get back to a time like this. But maybe at the end of this talk, we can more be a reefer cautious. As some people may have seen this commercial, I'm just going to take a minute just to highlight this trailer for reefer madness, just to kind of say where we were and where I hope for us to never be. Let's skip through a little bit. Oof. So that's strong. And we know since that time, we know where cannabis and marijuana has been. And we know that when we risk of dependence, for example, nicotine, such a commonly socially accepted substance, is almost a 32% risk of dependence with exposure. Heroin, obviously 23%, even alcohol, that is at every bar and every corner of our streets, we have 15%, marijuana being at 9%. Following up, we even know, like when we talk about toxicity levels or toxicity of different drugs of abuse, we know that things like alcohol, heroin, cocaine have a very high risk of misuse and as well as like toxicity, while cannabis is incredibly difficult to overdose. And so again, while we do come from a place of from the early 30s and things like reefer madness, and we've come such a long way in understanding this, we want to make sure that we're not repeating any part of history. And that's specifically with things like cigarettes, for example, when we have Dr. Batty's asthma cigarettes, and we talk about how more doctors smoke Camels than any other cigarette, right? The healthy cigarette, or even things like filters that were supposed to prevent us from having any, real damage from the cigarette. And so what I hope to have as a conversation today is talking about a balanced approach that, this general thing of ain't nothing free. And cannabis, while it can be incredibly useful for so many things, also has to be respected as a medicine like we do everything else. So some recent exposures, health risks and consequences. This has to do with poison control phone calls, exposures, right? So things like plant materials, majority oftentimes calls to poison control centers are co-use, so 61%, and almost 10% are actually very young children. When you think about things like concentrates, edibles, and vapes, majority is cannabis only, almost 80%, and you see that it's almost 30% are children 11 or younger. And when you think about things like this, there's a reasonable chance that it's either something like vape oils, or even unfortunately things like gummy bears, Laffy Taffies. If anyone has seen these have like sometimes, I've seen blackout brownies that are almost 1,000 milligrams in these small sizes, right? It's something that's very easy for a young child to get into, can be very attractive. Things that we've done in the past with cigarettes that we've moved away from, and we hope to be able to have a responsible move forward. So you can see here from early 2017 to almost the end of 2019, you already see a significant change in the phone calls to the poison control from plant-based material to concentrates, vaporizers, and edibles. Also, as we see as the extreme normalization and more frequent availability of it with recreational, legalization, you start seeing things like cannabis use disorder. At the end of the day, not very different from things like alcohol use disorder, opiate use disorder, TikTok use disorder, right? It really focuses on things like tolerance, where you start needing more, start craving it, interrupting or endangering regular life, and withdrawal. Really, at the end of the day, these are very similar things, and cannabis use disorder should be assessed and treated in a similar way and respected in that way as well. So the world of cannabis has changed since the golden days of Woodstock, right? And how has it changed? And mainly it has to do with actually every aspect of cannabis has changed. Modes of administration to start off with, things like vaped oil, cartridge pens, vaped ground or whole flower, capsules that can be things like chewable or orally disintegrating, liquids, oil tinctures, oral sprays, oral powders, even suppositories, which again have medicinal use, but also, as always, have a chance for misuse as well, things like lotion and gels. To continue from there, delivery devices have significantly changed. I'm sure everyone sees these days people walking around with vape pens. There's also vape with oil or vape with leaf itself. And on the right, there's something called dabbing. I'm not sure if anyone here has seen anything like that before, but you basically have to use like a butane lighter to light the bowl more or less, and then you melt this wax, and we'll see in the next slide. So this has to do with the concentration of THC, where historically or traditionally you had something like a 2 to 3, 5% THC. Now you have close to 60, 80, almost 98% concentrate. Things like hash oil, shatter, wax. These things are often used in the dabbing world. But again, understanding this is a incredibly concentrated use. So do we know if it impacts us differently? It's hard to say. We haven't been able to answer those questions yet. But we can say that the strength and potency of it is without a doubt significantly stronger than the THC we used to deal with. I mean, things like this, it's not a plant anymore. It's gone into our labs. It's taken a scientific level. And so you have derivatives that are containing almost 98% THC. Some very creative names, things like earwax, which honestly looks like it, butter, shatter, hash oil capsules. And, so again, while a lot of our early data and early studies talk about how cannabis might impact us, positives and negatives, this is a whole different world that also, again, we need to ask some similar questions too, and to look for the right answers. This is from right down the street. In New York State, we have regulated licensed cannabis shops that follow the rules. We know what the product is. And this is just I call this a shameless smoke shop. Why do I call it shameless? It's not licensed. It's not regulated. They didn't let me take a picture in the back, but it's every type of roll, dabs, cigarettes, dog walkers, everything that you can possibly imagine with no knowledge of where it's coming from, what it's mixed with, And you have these like just signs that are attracting, all types of ages of people. And this is on the Upper East Side, open from 9 in the morning till late at night. Also, they also do things like psilocybin chocolates. Again, who knows what's in there? It's completely unregulated, and it needs to be treated like a medicine, like everything else. Just to kind of bring the point home here, you continue to see that this is even like an older slide, right? That THC has continued to increase, since the 1960s. And the bottom little slide there as well, that little kind of line is the strength of CBD and exposure to CBD. But really, it's the THC strength that has gotten significantly stronger, that we're seeing more and more present. To me, this slide really kind of says something. What it highlights to me is this is one of the largest monitoring the future survey. They ask a lot of questions. And as far as percentage of the youth that use these different substances in the previous month, 8th, 10th, and 12th graders, alcohol and cigarettes have both gone down. Honestly, I think that some of these numbers have probably changed recently with the availability of nicotine vapes and Juuls and things like that. But you see that cannabis and marijuana actually has stayed the same. So relative to alcohol and cigarettes in this time frame, it's kind of relatively increased because the others have so significantly decreased. And I think the future is going to tell us what's going to happen with these nicotine vape pens, but that's not the point of today's topic. So we kind of know this, to kind of summarize what we just talked about. We talked about where we were, reefer madness, really so much misinformation, so much racism, so much legal aspects of it that really impact us in a negative way. While simultaneously, we've gone to a whole new world of what cannabis is in regards to potency and impact and how we can do, and how we just need to be more aware of it and really give it the respect it kind of deserves. I can't tell you how often I have patients I ask, do you drink alcohol? No. Do you do any drugs? No. And then you can kind of smell the cannabis, and I'm like, oh, do you smoke marijuana? And they say, oh yeah, that, but that's not a drug, right? So we want to make sure that we continue to respect it. And so now we're going to be transitioning. We're going to be discussing about circle of life, kind of evaluating how cannabis may or may not impact different aspects of our population, right? So to start off, perinatal impact, men versus women, what things matter. So for men, for example, these are often studies that are done, and then they are often contradicted. And it's also very difficult to assess causation and correlation. And so they make these very significant statements, and then there's some different levels of strength. And again, I hope that we move in the right direction. So let's say, for example, male preconception, marijuana use, and a spontaneous abortion. Studies show that almost an odds ratio of 2 or 2 times more likely that preconception use for people had a spontaneous abortions with paternal use more than once a week. Smoking marijuana more than once weekly in the preceding 3 months, they had almost an N of 1,200 associated with a 30% reduction. So almost a third reduction in sperm count. What does that mean? Does that mean it was harder to conceive? Or there are higher issues? These questions continue to need to be asked, and hopefully we start getting answers. And that's kind of the highlight, right? Contradictory results, they're observational, they're often retrospective, they're often confounded by polysubstance use, they're often self-reported use. There's no understanding of potency, modality, and frequency in a real way. But sperm motility and morphology were considered to be unaffected. So oftentimes these studies almost contradict each other, and it continues to leave this very confusing message. Various aspects contradict each other with chronic use. Sperm count, probably best evidence that it does decrease our sperm count. Abnormal sperm morphology, reduced motility, reduced fertilization capacity, right? The ability to procreate are really questions that continue to be unknown. And even then, the reproduction rates may be unchanged. There is some more limited data, but they're all in animal studies. They show testicular atrophy, reduced libido, and sexual function. And none of these studies have been replicated in human clinical trials as of this point. So then you start asking continued potential impact. How can it impact us, right? Not only may there be issues if you can get pregnant, but how it may impact your future children. You can see I'm continuing to kind of stay on this side of we don't know, and they keep trying to do the best to find out those answers, and it continues to be a question. There's some data that show that aneuploidy, diploidy, all these kind of chromosomal abnormalities were higher in cannabis users compared to non-cannabis users, but often, again, a lot of confounding factors, very low ends, very low number of people involved in these studies. And then it says, does cannabis exposure lead to sperm change at a nuclear level? Strongly, they'll say yes. Again, with a sample size of 54 people, So again, you have to take it with a grain of salt. Females, I do want to highlight some positive. So chronic pelvic pain, unfortunately, approximately 15% of women suffer with it. And we know that through the endocannabinoid system that the cannabinoid receptors are highly expressed in the uterus and other non-reproductive tissues. And so in small studies, it shows that almost a quarter of women, almost a fourth of women are using it to help them with their pain. You have things like menstrual-related symptoms. CBD in low and high doses reduce their symptoms, their irritability, anxiety, and they're feeling that they were managing their symptoms and their pain in better ways. And again, a low N. Very limited data. Questions weren't being asked. So it's important to recognize the fact that there's a need for knowledge. I'm going to keep saying that throughout the day, throughout our hour together today. So we know that there's a significant amount of use of cannabis in pregnancy, especially as it becomes more and more available. And generally, it happens in the first trimester, often before the patient realizes they are pregnant. Not enough education of potential impact, and even then, too much stigma. Unfortunately, oftentimes you hear patients say that if my doctor told me that they even heard that I smoke cannabis, they would discharge me from their service. I know that in the world of opiates and that we deal with so much, especially in my large tertiary care hospital, that would be unheard of. We would refer them to addiction specialists, to pain management. We would never tell them that we would discharge them from our service. And so we have to do better. So not enough healthcare workers know what questions to ask. During the Ontario study, which I'm going to highlight in next slide, if there's a mildly increased finding of autism spectrum, 4 out of 1,000 compared to 2.5. But again, it's very, very significant limitations. Chart review, multiple confounders, polysubstance use, cigarettes, alcohol, etc. And so, obviously this is a very difficult study to perform, but again, it's hard to say what it actually is the cause, especially as the definition and diagnosis practices for autism spectrum also continues to change. Other things that are just theoretical exposure when they discuss is based on how and where the endocannabinoid receptors are, especially in the brain. They discuss about how it can potentially impact maturation, neurotransmitters, right? So dopamine opiate systems. So there's a concern for potential future illicit drug use and addiction. Based on all these things, they findings with the spontaneous miscarriages, the fetal brain cells shown in patients that are using cannabis during pregnancy that have a reduced amount of dopamine receptors in areas of interest for concern for addiction, like the amygdala and the nucleus accumbens. Whew, that was so far, okay? So to highlight some 3 major studies that have been going on, there's something called the Ottawa Prenatal Perspective Study, looked at almost 700 middle-class, low-risk people, evaluating the effects, and then the patients are being followed. Maternal health practices and children development study, almost 565 high-risk, predominantly single pregnant women, effects of prenatal alcohol and marijuana exposure, being followed for almost 14 years. And the Generation R study, almost 10,000 women living in the Netherlands, which is an ongoing population study on a large scale, and the offspring will be followed into early childhood. And then we continue going into the potentials. And some of these, I have to say, are almost in a way contradict each other. That here, in some of the studies will say that it's finding fetus neonates, decreased gestational age, lower head circumference, increased startle response, tremors, infant child, decreased memory, verbal scores, decreased mental development. And again, identifying how cannabis has changed, how education about cannabis has changed. So these things can often be considered to maybe even be a little outdated. But this is the best of what they can come up with at this point, and even then often contradicted with other studies. And even findings of in adolescence, visual memory, verbal reasoning, decreased IQ scores. And unfortunately, to the young adult, this is about perinatal or prenatal exposure, right? So decreased response inhibition, increased psychosis, rates of marijuana and tobacco. And it's so difficult to say about confounding factors, correlation and causation. But this is what they're coming out with. And that's why we're talking about it today. Across these 3 major studies, though, it happens to be the most similar findings has to do with preterm births, miscarriages, pregnancy complications with spontaneous miscarriages, and low APGAR scores. APGAR scores have to do with basically how the child appears when they're born and 5 minutes later in regards to appearance, pulse, grimace activity, and respirations. Impact of perinatal exposure into childhood. So the Ontario study at 4 years, impaired mental development, memory, learning, verbal parameters. Maternal health practices study showed some impaired mental development at 9 months of age, but then say that they catch up and equalize, right? So almost in a way, when they compare head to head, 9 months, it was found to be impaired, but then normalized later. And again, even another study and Generation R did not find those similar deficits and found some possibility of increased aggression and inattention in young girls. So really, while we do ask the questions, we still haven't definitively found how these may impact. And again, full disclosure, other smaller studies show no difference in development, size, etc. So these are major studies, and people are asking questions, and they continue to be very difficult to perform with many confounding aspects, tobacco, other drug use, also missing data for the quantity of use, the timing related to pregnancy. And so it's hard to say what that true impact is going to be on different levels. Breastfeeding, another aspect of the unknown, incredibly limited data and very much on a theoretical, right? So we have a 99% protein bound. Again, it's theoretical. 99% protein bound, liposolubility, meaning that the general idea is that THC is crossing over into the breast milk. And how is it an active state? Is it impacting the child after birth? So one study, 27 mothers, active cannabis use showed no difference in growth, mental, or motor, but maybe shorter. That's what they kind of highlighted. And I was like, okay. Another showed dose-dependent reduction in motor development without mental delay, while another showed sedation, more drowsiness, some growth delay, low tone for sucking. So who of you knows what's best? General recommendations from most OBGYNs and from the ACOG, the American College of Obstetrics and Gynecology, will say no cannabis use in breastfeeding, as well as during pregnancy, but we haven't found definitive proof. Now transitioning, we talked about men, we talked about women, we talked about pregnant women, breastfeeding. Now let's discuss the best data that we have from young bucks to young adults. Potential longer-term effects of regular marijuana use on youth development when we talk about things like the frontal cortex and development of the executive function. So issues with attention, memory and learning, poor education, and life outcomes, loss of IQ for persistent heavy users in very young ages, potential for addiction to marijuana and increased risk of addiction to other drugs, again, having to do with the dopamine receptors and nucleus accumbens, and again, kind of focusing on a lot of confounding opportunities. Is it because of there was cannabis usage, or is it because of availability of cannabis? That's always the old school, is it a gateway drug or not? Best data says it's not, it's just the most available. But these are questions that we continue needing to ask. And increased risk of psychosis. We're going to get into that in a second. So deficits in cognitive functioning among those activities. Many studies show that adolescents who use marijuana heavily tend to score worse, and not only when they're intoxicated. So when we talk about things like verbal learning or delayed recall, people who are young adolescents and teenagers who were frequent users had a change in scores for verbal learning, delayed recall, as well as memory and processing speed. Sorry for the blues. Other deficits that were noticed are larger for those who use more and for those who began in younger age, right? So more frequent use, higher concentration use, and those who are at a younger age. With sustained abstinence, so here, even at 3 weeks of abstinence, the verbal learning trials basically normalized, and that's an important thing to highlight here as well. And again, it has to do with at what age was exposure initiated. Other metrics that people use for adult life outcomes have to do with college graduation. And it talks about the fact that people who are number of occasions that use marijuana from that early age of 15 to 21, the more frequent they use, the less likely than to college. And I think that's what a big statement to make in such a major journal. And simultaneously, I think it's too bold. I mean, I think it could be so many reasons and so many confounding aspects here, and I'm just going to keep emphasizing that causation, correlation, very, very difficult to attain here. The most comprehensive study, so loss of adult IQ associated with marijuana dependence in adolescents, right? The best study we have so far is something called the Dunedin study from New Zealand, where they've followed kids born in 1972 to 1976, of almost 1,000 people, where they checked in on them, assessed IQ at ages 13, at 13 until age of 38. At 5 different check-in points, they flew these kids in, and it's still an active. Over 1,000 papers have been published using this data, where they do blood tests, cognitive tests, computer tests, and they also assess for marijuana use and dependence at 5 points in that time age. They did their best to control for use of alcohol and other substances, as well as socioeconomic status, years of education. Their findings showed a decrease in IQ that did maintain and persist into adulthood. The longer their dependence persisted, they said about an 8 IQ point difference. I don't know about you guys, but personally speaking, I could not really afford 8 IQ points. So it's something that I think is concerning. And again, it focuses on earlier exposure, more impact. Those who began in adulthood did not show that IQ decline. And quitting adulthood did not restore the functioning of those who began in adolescence. So really, in a way, during those important years of development in those early years, those changes stayed with them and were persistent. Again, as I keep emphasizing, in these major studies, the Morkes and the ISIN, again, showed over 2,000, the first one, over 2,000 young people in the UK assessed an IQ between the ages of 8 and 15. No association found with change in IQ, even adjusting various confounders. 800 pairs of twins. Users experience declines as they're non-using, as marijuana users experience declines in their IQ, as well as their non-using twins. So again, no associated difference. And so I'm trying to, I hope to understand the theme here is that there's a lot of contradictory data, and I'm just doing my best here to bring up everything for a proper education and a good conversation with our patients and our loved ones. This has to do with, everyone talks about the increased risk of psychosis in regards to marijuana. And oftentimes it really has to do with showing that if you're not susceptible in regards to the genetics or gene specific for schizophrenia, really did not show an increased odds ratio, significant increased odds ratio or likelihood of developing it. But if you were susceptible, cannabis was a significant increased risk. This was published almost about 10 years ago. Transitioning, make sure I have time. Elder danger. We know these days, and we see it. I've given a couple of talks to senior homes and elder populations. Little Johnny's coming home from college and saying, "Hey, Grandma, I know you have this arthritis pain. Maybe this will help you. Here's a small gummy. Here's an edible." And maybe it might, and including some topicals and placebo effect, whatever it may be. But we know that elderly have unique population, unique issues in regards to what medicine they're taking, cardiac history, and cardiac health. And so there's some definitely differences, and often has to do with liver metabolism. And so things like warfarin or Coumadin, which many of our older patients are on, THC and CBD increase their warfarin levels. So you would have to track that very closely. Alcohol increased. Theophylline, not that often. HIV medicine. Clobazepam, which is also can be used for epilepsy, could be shown to increase those levels, which could be associated with lethargy and drowsiness. Other medicines with cannabis that we need to be cautious with. Sedatives. Often elderly people do suffer with insomnia. So some common medicines are going to be, they might be co-ingesting. Some medicines like their pain medicine, as our population does get older, more and more people are on opiates and strong opiates like codeine and Vicodin. And so those might be increased levels. Anticoagulants, like we just discussed with Coumadin. And so these things just need to be, it's very important to have a destigmatized and open conversation so we're best able to take care of our patients, as well as antidepressants. Absolute contraindications from the official recommendations continues to be either acute psychosis or other unstable psychiatric conditions, young or elderly. Relative, we know that sometimes patients can have bad reactions to THC, including things like anxiety, or they can have some fast heart rates that can induce certain arrhythmias. So that's severe cardiovascular, neurological, those kind of diseases, and can really exacerbate certain arrhythmias and the pregnancy we already discussed. Cannabinoid hyperemesis syndrome, something I really do want to discuss because I think it's very dear and close to heart. So this is us transitioning to a different kind of topic here. And what we're discussing here is what we see, and anyone you speak to who's an emergency physician sees in the emergency department. It's been on a significant rise since about 2004. It has to do with oftentimes daily frequent users. So the symptom, the definition often is recurrent nausea, vomiting, and cramping abdominal pain. And often that occurs due to prolonged high-dose cannabis use. And this really kind of sad truth or reality is most ED docs and pediatricians and family doctors can tell a croup cough from their hallway or from their waiting room. And I think at this point, most emergency doctors can identify a hyperemesis wretch because they have nothing else that's going on and they have nothing else to vomit out. but you hear it, and it's often very young people, very concerned parents. And so we're seeing it in a huge rise. And I just want to make sure there's awareness about how this is going to continue to go up as possible concerns for over normalization. So 7 characteristics of the cannabinoid hyperemesis syndrome. Almost 100% of people that suffer with this have a history of regular cannabis use, cyclic nausea and vomiting, at least weekly cannabis is 97.4. Their symptoms get better after stopping cannabis. Some may know, I know this is a very well-informed group about cannabis and the endocannabinoid system. Cannabis can continue to kind of leak out of some of our fat cells for prolonged periods of time. So they couldn't have abstinence for 1, 2, 3 weeks and still have these severe symptoms. And I'll tell you from personal experience, we see this every day. We see patients, young people who are suffering with this every day. And it's something that needs to be addressed, and we need to be educated on how to manage it, how to identify it, so we can do proper treatment. Often one of the kind of telltale signs of it is a compulsive hot bath, that they feel some symptomatic relief. Like they get kind of a tolerance to that hot bath, but they feel like they'll tell you they're vomiting, and the only thing that helps them for a little while is a hot bath. And they have this kind of rigid abdominal pain. Unfortunately, due to the level of abdominal pain they're having, they have very many CAT scans, and you can see it in the medical record system. And often the CAT scans are totally negative. And it happens to be a male predominant disease at almost 73%. And to kind of finalize and highlight here, what's important here is obviously to identify it, to be able to have a destigmatized language with our patients and loved ones, but also to understand, personally speaking, and I think most of my colleagues will agree with me, is that the general Zofran, IV, oral disintegrating tablets, they don't really work. Often we need to give antipsychotics, frequently more than 1 dose. So it'll be either Haldol, and nowadays droperidol is back on the market. So you give 2.5 or 5 milligrams. Capsaicin is kind of a topical pepper. People often place it on their stomach. Caution to the wise is to make sure they don't touch any mucosa or eyes that will burn them. With droperidol, haloperidol, especially these antipsychotics, be very, very careful. Always get an EKG, to be always cautious about QTC prolongation. I personally prefer always IM versus IV, but that's some people would disagree with me on that. Benzos will work. They'll feel better. About an hour, 2 hours later, they'll be able to tolerate some pills or some food, some crackers. Often go home, and then 6, 8, 12 hours later, they're back in the waiting room. They're back retching, and they're back in a lot of pain. So they often get admitted just for prolonged hydration and repeat dosing. That is all my lecture. I also want to say thank you to the ACS for letting me speak about something that I'm very passionate about. I hope the lecture highlighted that there's still a lot of questions to ask, a lot of answers to look for, hard to attain between causation and correlation. But I'm happy to be working with ACS, and just to highlight, their hope, and I think what McKenna spoke about earlier, increased standard of care for patients, education for referring physicians, why we're here today, education specialists, improve dispensaries, encourage research, improve law and regulation. And any follow-up questions, anyone feel any other questions to ask me personally afterwards, please feel free to email me. I love to have these kind of conversations. I hope that wasn't too much too fast. Thank you so much for giving me the time. And I'll gonna stop sharing my screen and hope to have a conversation.
Awesome. Thank you so much. I got a lot of that presentation, so I really appreciate it. If anyone has questions, you're welcome to put them in the chat or raise your hand if you want to speak. It all works.
So I have a question. You look like a relatively young doctor. Do you think medical professionals are being taught all of this on cannabis? Or do you think there's a lack of education?
There's still a significant lack of education, but I will say that I work for Northwell Health, and I work in the medical school, and we have an entire week dedicated to the students talking about substance use disorder, and we have hours of cannabis education, and also about proper education, destigmatize positive type language, identifying things like screening, brief intervention, referral to treatment versus your urine was dirty and you're an addict. Now we say, how do we discuss harm reduction? How do we minimize exposure? How do we have a proper conversation? So that is not just our place. So it is getting better, but we're still not there yet.
What about retroactively teaching doctors? Because I used to be community engagement for an MSO. So I
Right.
had a lot of conversations with in New Jersey with doctors and calling them up and saying, what do you know? And I found that a lot of them, even though they were recommending doctors, they didn't know a lot about it. And so either they didn't recommend it to their patients, or when they did, they were very cautious about it. And I'm not 100% pro because I don't think it's for everyone. But it was funny. It was like, well, you're a recommending doctor, but you seem very ignorant, the word I would use, or illiterate in the subject.
Literally, yeah. No, I think you're absolutely right, and then I think that yeah, you're right, and I think that that has to be a continued education. But we're at a place where, unfortunately, and I say this about the opiate epidemic, is that we're in a sinking ship, and we need to clog the holes as best we can. And
Okay.
so the next generation of physicians is better. They're much more socially engaged. They are much more positive type language, and so that's the right step in the right direction as they graduate. And honestly, they're also much more bolder in
Mhm.
regards to discussing with their attendings. And I'm seeing it on a daily basis, and not daily, but I see it on a regular basis where they're like, oh, hey, I read this paper, I read this trial, can I show it to you? And they're having a much more open conversation with their attendings compared to even when I was a resident not too long ago.
Okay. Just curious. Thank you.
No, thank you.
And wonderful presentation, by the way.
Thanks so
I
much.
went to Colorado for the Cannabis Research Conference, and it was really enlightening. And the findings that I came away with was that it's really not recommended for women during childbirth or the pregnancy stage. Yeah.
That's my official recommendation as well.
Yeah. Yep. Thank you.
Thanks.
Right. So we did have a question in the chat asking about if your peers are educated on this. And I do want to add that that is the whole mission with the Association of Cannabinoid Specialists, is to get doctors and other healthcare workers engaged and learning about this cannabis science. Anything you want to add on to that from your personal experience? Go for it.
Yeah, so Diane, I think that's a very similar question. I mean, and so that was really engaging with the realities of how do we, I don't think they are as educated as they were. And I think oftentimes, unfortunately, there's a lot of stigma. Like I said, hey, if you even tell me that you use cannabis, I'm going to discharge you from my service, is just the opposite of what we're supposed to be doing here. And we would never do that in regards to the opiate crisis ever. We know it's more dangerous to withdraw and everything else. And I see no reason, not to say that this is obviously, as I highlighted, this is not the same toxicity, but having such a kind of a nasty or negative approach to that conversation is the dangerous part. The point of our job here is to take care of our patients and we're the last guys they should lie to or feel like they should lie to. And I say that all the time to my patients.
Absolutely. We do have another question from Frederick, has his hand raised. I'll let you go with that, Frederick.
Okay, back in the day before all the medical cannabis came about, I saw patients who had gynecomastia.
Yeah.
And cannabis was blamed as a cause, but in recent years, I've never seen anyone mention that in the risks of using cannabis. Have you seen that in your review?
No, I have not actually, and that's a great call, Freddie. We hear that all the time about gynecomastia, estrogenic type drug, and yet that has never been associated with men or in any way a pro-estrogenic receptor agonist, right? For even women as well in regards to trying to get pregnant. Really, the male aspect of testosterone and maybe sperm motility and sperm count, I think the sperm reduction is I think that is going to hold up. The gynecomastia I haven't seen anywhere.
Okay, thank you.
All right, awesome. So we have another question in the chat asking about if there are any other grad or post-grad programs besides the U Maryland Baltimore's Medical Cannabis and Science and Therapeutics program, if you're aware of any other graduate programs that actually focus on cannabis and pharmacology.
I would have to get back to it. I feel like Jordan might be a better person to answer that question. I know that ACS has an incredible library and I've been enjoying learning so much even extra about things like terpenes and and CBD and cannabis even on my own, because we really don't talk about it too much. And I think that ACS is an amazing resource for you. And I really especially recommend becoming a member or seeing what education is available there. There are programs, but often, unfortunately, there's more like how to be a bud tender or how to open up these shops and all this other stuff, because unfortunately.
I'd like to interrupt on that. A
Please.
year ago, I reviewed all the programs in the country.
Great.
And I came across about 6 or 7 master's programs across the country. So University of Maryland is not the only one, but they are regional. There's some on the West Coast. There's dozens of programs like you mentioned that offer training relative to the industry.
Yeah.
From the medical point of view, there are about 6 programs that do have a concentrated master's degree related to a university, but the requirements are not necessarily that the person has to have a medical background to get the master's.
Thank you,
Right.
gentlemen. I appreciate that. I was the one who asked that question. Aloha from Hawaii.
Thanks.
Thank you
You know,
so
I'll tell
much.
you, it's go ahead.
Yes,
I'm
please
sorry.
go ahead. No.
What are the issues we have? You know, that's a big, I think, common philosophy that Jordan and I share and the team at ACS is that cannabis needs to be treated as a medicine that it is. And even when we certify, so let's say we provide cannabis as a palliative care in our cancer center for our hospital system, and yet it's not a prescription. Everything I provide to patients is a prescription, and yet cannabis specifically is a recommendation. It's a certification to say, hey, now you have access to it. And that doesn't exist with anything else that I write with my medical degree. And that does not deserve to be unique compared to every other medicine and every other drug that I get.
It's true, and it's funny that the medical industrial complex are the people that actually are lukewarm to the idea of cannabis as medicine, and that's disappointing. When physiology books, texts that people read in American medical schools have no mention of the endocannabinoid system, I'm sure people like Raphael Mechoulam, rest in peace,
Right.
sir, are just it's sad.
I think it's interesting because it's had the psychedelics world also has similar issues. Is that you can't patent a plant. That's an FDA rule. So what they're doing around it, what they're trying to do is profit off the industry instead of the kind of maintain safety regulations of the plant itself. And we have the same issue with psilocybin and other aspects. So that's kind of part of the conversation. And that's why cannabis is different. That's why it doesn't have that same hunger to regulate, control it, because they can't profit from it. They can't patent it in that same way from the pharmaceutical industry, at least.
Yes.
Awesome. Thank you for expanding on that so much. That was very helpful. We do have another question in the chat. We did touch on this a little bit. If we go a little more in depth, how do you navigate conversations with patients to trust their healthcare providers to disclose their cannabis use without fear of judgment or getting in trouble?
For the conversation with patients to trust their healthcare providers. Just to clarify, Tirza, the question is us as the provider, how do we navigate it with our patients? Is that the question, or is it more in reverse to make sure that when we talk to our healthcare providers to disclose their account without fear of judgment or getting in trouble? How do you navigate conversations with patients to trust their healthcare? I understand what you're saying. I mean, at the end of the day, I think it starts off with conversations like this to normalize that this is happening. And if we continue to keep it in the dark world, then I think it's going to be our dangerous aspect. But if you're asking, how do we get conversation with patients to trust their healthcare providers? At the end of the day, there's a generation of physicians, nurse practitioners, PAs that are coming from a generation of reefer madness, right? 19 war on drugs, and we know often about it's very racist, very anti-hippie, anti-Black Panther movements to try to. We know the war on drugs has been lost, and we have ruined many families and many communities due to that war. And so we're moving in a certain direction, but we have to also, learn from history. As I started the lecture.
All right, we
Thank you for the
don't have
question.
great questions. We don't have any other questions in the chat right now. Opening it up to anyone, questions, comments, concerns.
I'm going to put my
All right.
email address in the chat if anyone has any questions in the future, or I'll do my best to refer or answer as best I can.
All right, we do have another question. So, what are your hopes moving forward in general?
My hopes for moving forward. I think the reason my motivation to have these lectures is because I'm worried about how it's moving forward, to be honest. I walk the streets of New York City, and you smell cannabis everywhere. It looks like it's advertised towards children, and I'm worried. I'm very worried about it, to be honest with you. And I appreciate the potential benefits and opportunities that cannabis has for our patients. And I don't want the pendulum to swing back to prohibition. And I don't want it to swing back to stigma. And I don't want it to swing back to everything that it was, because it really has a significant potential to do good. And I just worry that by that, not to be too much into it, but that greed will make it go back to what it was. And we need to do the right thing so we can keep this medicine to help our patients.
Awesome. So I just want to follow up on that too. You talked about these storefronts, and these aren't dispensaries. Can you just talk about why they're different from dispensaries and not as safe?
Well, we don't know what they're being mixed with. We don't know. There are findings of there's no regulation on where the plants are coming from, what oils are being used. We can even discuss about, for example, when we had that scare with popcorn lung, right? Vape-related lung injury. It was a few cases, it wasn't that many, but it was severe lung injury in very young people. And in general, it was findings that it was mixed, these fake vaporizer pens that came from, I think it was from China, mixed in with vitamin E to fluff up the oil. So while vitamin E might be good as a supplement, as a pill, not very good in the lungs. And so the benefit of a proper dispensary is that they have to be regulated. The unfortunate problem is, and I think we've seen this happen in Canada as well, is that by enforcing regulation in a certain way, the black market wins because they don't have to do the financial expenditures of regulation. But by removing some of those obstacles, then maybe the regulated dispensaries can be a more profitable. It has to be in some way subsidized, because this is the next generation of leaders and bosses and parents and everything else. But it is very, very scary for us, what we're seeing. And I can have dinner I live on 84th and right here near 2nd Avenue, and you can have dinner in one corner, you'll see 3 different weed shops. And they're not just, oh, I saw weed shops with munchies and candies and graffiti, and it's very cool and it's very bright, and it's right near, where so many children are eating. And so we start by having conversations like this. We start by having destigmatized, positive type. And I say this all the time, and I said it during the talk, like, we're the last guy to lie to, and we need to be transparent. But we also have to be informed. I think we have to speak the language of our patient. I find this as an issue in the addiction world all the time. They use words that our patients don't use in a lot of ways. And so you come off very isolated, separate from them. And we really need to meet them where they are. That's our mission. We're not here to be high and holy. We're here to help. And so that's kind of the way I come at it.
That's a great response. I really appreciate that. We do have a few more minutes if anyone else has questions, comments. If not, he did put his email address. You can follow up later. We are open for discussion. Oh, Lauren, please.
Yeah.
Can you hear me?
Lauren. Yes.
Oh,
All the way from
okay.
Hawaii.
Concerning what the gist of what I get out of your great presentation was standardization is key to everything. Standardization of doses, standardization to standardize cannabis as a medicine. That, I guess, is what we're really talking about in the end, right?
100%. 100%. That's why so many of these studies were based, not useless. Of course, I'm not going to say they're useless. They put a lot of work, a lot of hard work, a lot of resources, grants, but it really comes off that there's so many confounding factors. And we talk about it, right? The golden days of Woodstock, you might have needed 2 or 3 joints to feel something, and now you can have 2 hits, right? So because we don't know if it impacts you in a worse way, but we know that the potency is through the roof. I think I saw a stat from, yeah.
The X factors are through the roof when you're talking about these experiments, but that's just going to, when the research furthers and furthers. But outside of America, I mean, look at what they've done in Israel. They were giving cannabis to the nursing homes, to the elderly in the nursing homes. They're such a smaller country that they can act. They can act. It's not the red tape of the quagmire of Congress that we have over here. But anyway, I'm rambling. But my point is that why can't more people recognize the research that's done outside of the United States, like Dr. Cristina Sanchez of Spain University, other people, Raphael Michelin, obviously. Ethan Russo is a famous American cannabis researcher. And I just think that his research is so unbelievable. I don't see why these people say, oh, there's not enough research done, when it's probably the most researched thing in science right now.
I think the prospective aspects of it, we often find so many times our studies will come out, even our trauma stuff will come out from Canada and Australia and let's say Israel or other parts of Europe. The reasons why often is because you have this kind of socialized healthcare system, positives and negatives of it, and we will not get into that today. But understanding that when you have a centralized system, you have a centralized data for it, and you're able to assess and really follow people in a long way. I don't know the antibiotic resistance panel of a hospital 10 minutes away from me in New York City, right? So, and that's just the tip of the iceberg into the dysfunctions of certain aspects of healthcare. And also, again, Lauren, I think to your point is the stigma associated with any kind of drug use forces it to stay in the dark. And even like Alicia here's question of how much CBD do I see? It refers back to, hey, do you use any drugs? No. Do you drink alcohol? No. Do you smoke cigarettes? No. Do you do any drugs? No. And it's like, okay, but cannabis, and they're like, oh, that's not a drug, right? There's this understanding that it's just nothing, and that also is not the right thing. It also needs to be understood and respected because it's that important to us. So it's a great question, and I can only hope for the best. It took us some time to, even this, a great example. The New York State requires us to ask about cigarette use, right? They have to link finances and resources to it. And that's how we're able to ask about cigarette usage. And that's how we're able to do it, because reimbursement time wasn't there. So end of life care, for example, and cigarette usage and inhalation, because you have 8 minutes for a CMS, for Medicare, Medicaid appointment in New York City. 8 minutes,
Right.
you don't have time to ask them, what they ate for breakthest.
How much time they have in the labor and delivery room, they only got so much time in labor. I'm sorry, you got to have a cesarean. Do you have time?
Well, that's a whole other thing. Yeah, that's a whole other thing. Yeah, exactly. So I see a lot of CUD, and I think a lot of people, it's hard to say, right? Because when you see, let's say, opioid use disorder, we have overdoses, we have significant nodding off, we have respiratory depression, we have intubated. Versus cannabis disorder is a much harder thing to identify. It's not as stark. It's okay. I'm not really, maybe you can argue some people are less motivated, or some people have, like we talked about, with decreased going to college. So it's not as stark as alcohol use disorder.
I'm sure that diagnosis is just so hard to nail,
So hard to nail.
When presents in the ER. I was
Exactly.
a medevac paramedic in the Army.
No, I'm sure
long time ago.
Saw a lot. I'm sure you saw a lot.
I have a little bit of experience.
Yeah. Thank you so much for the conversation and the questions. I hope that these are just the early parts of our conversation, and we can continue to move forward, and that it will spread out and have a good conversation.
The discourse tonight has been excellent. Really appreciate you, Dr. Vortsman, and everyone who's participated. We are going to start wrapping up. Please be sure to go through the chat. If there's any email addresses or links that are in there that you want, please grab them. If not, we do have them available. We can certainly get them to you. Thank you all for coming tonight and for participating and just being part of this community. We really appreciate you, and we hope to see you at more ACS events. Thanks so much.
Thank you.